Welcome to Pediatric Case Review. Today we present a comprehensive case-based review of tyrosinemia for general pediatricians. This lecture covers 14 clinical case challenges addressing neonatal liver failure, neurologic crises, skeletal deformities, pathophysiology, newborn screening, laboratory monitoring, ocular and skin findings, pharmacological therapy, dietary management, cancer surveillance, visual complications, renal tubular dysfunction, treatment titration, and clinical odor recognition. This is an evidence-based review aligned with current guidelines. Let us begin. Case Challenge 1. A 3-week-old male infant is brought to the emergency department with progressive yellowing of the skin and eyes since day 5 of life. On examination, he has icteric sclerae, firm hepatomegaly with the liver edge 4 centimeters below the costal margin, and a distended abdomen. Key labs show international normalized ratio of 4.5, which is severely prolonged. Total bilirubin is elevated. Aspartate aminotransferase and alanine aminotransferase are mildly elevated, and alpha-fetoprotein is markedly elevated. What is the most likely diagnosis in this neonate? Option A, Tyrosinemia Type 1. Option B, biliary atresia. Option C, galactosemia. Option D, Alagille syndrome. The correct answer is Option A, Tyrosinemia Type 1. Acute liver failure in early infancy is the hallmark presentation of tyrosinemia type 1. There is a classic paradox: severe coagulopathy and hepatomegaly with only mildly elevated transaminases. This is because the liver damage is driven by toxic metabolite accumulation rather than typical hepatocellular inflammation. Markedly elevated alpha-fetoprotein, often exceeding 100,000 nanograms per milliliter, is a key distinguishing clue. The pathophysiology involves deficiency of fumarate acetoacetate hydrolase, the final enzyme in the tyrosine catabolic pathway. This leads to accumulation of fumarate acetoacetate and succinylacetone, which drive hepatocyte destruction via oxidative damage. Nitisinone blocks the pathway upstream to prevent this accumulation. Biliary atresia shows conjugated jaundice without alpha-fetoprotein spike. Galactosemia has a slower onset with a different metabolic profile. Neonatal hepatitis shows typically markedly elevated transaminases. Case Challenge 2. A 2-year-old boy with a known metabolic disorder presents with his 3rd episode of severe, poorly localized abdominal pain. His mother reports sudden onset leg weakness, and he is now showing hypertonic posturing. He is irritable and hypertensive. What is the most likely diagnosis? Option A, acute appendicitis. Option B, acute intermittent porphyria. Option C, neurologic crisis of tyrosinemia type 1. Option D, intussusception. The correct answer is Option C, neurologic crisis of tyrosinemia type 1. This is caused by delta-aminolevulinic acid accumulation. In the tyrosine catabolic pathway, when fumarate acetoacetate hydrolase is deficient, succinylacetone accumulates. Succinylacetone is a potent inhibitor of delta-aminolevulinic acid dehydratase, which blocks heme synthesis. As a result, delta-aminolevulinic acid accumulates and becomes toxic to peripheral nerves. This mimics acute porphyria, presenting with severe abdominal pain, peripheral neuropathy with weakness, paresthesia and areflexia, and hypertonic posturing that may progress to respiratory failure. The key clinical pearl is neurologic crisis in tyrosinemia type 1 is porphyria-like. Always check urine delta-aminolevulinic acid if tyrosinemia type 1 is suspected. Case Challenge 3. An 18-month-old boy is brought in for bowed legs and poor growth. He was born full-term with no family history of bone disease. On examination, he has bilateral genu varum, wrist widening, and frontal bossing. Labs show phosphate is low, calcium is normal, alkaline phosphatase is elevated, and vitamin D level is normal. What is the most likely diagnosis in this child? Option A, vitamin D deficiency rickets. Option B, hypophosphatasia. Option C, X-linked hypophosphatemia. Option D, hypophosphatemic rickets due to tyrosinemia type 1. The correct answer is Option D, hypophosphatemic rickets due to tyrosinemia type 1. Tyrosinemia type 1 causes renal Fanconi syndrome, which is proximal tubule dysfunction. This leads to phosphate wasting, resulting in low serum phosphate and subsequently hypophosphatemic rickets. The clinical consequences include bone deformities such as genu varum and wrist widening, growth failure, and rachitic radiographic changes including cupping, fraying, and bowing. The key distinguishing features from other causes of rickets include vitamin D deficiency. Rickets has no liver or renal involvement. Hypophosphatasia has low alkaline phosphatase, and X-linked hypophosphatemia is genetic with no liver disease. Tyrosinemia type 1 uniquely combines liver disease, Fanconi syndrome, low phosphate, and detectable succinylacetone. Treatment is Nitisinone. Case challenge 4. A 6-week-old infant is diagnosed with Tyrosinemia type 1 after newborn screening detects markedly elevated succinylacetone. The Metabolic team explains that a specific enzyme failure causes toxic metabolite accumulation in the tyrosine catabolic pathway, which enzyme deficiency is responsible for the accumulation of toxic succinylacetone in Tyrosinemia type 1. Option A, fumarate acetoacetate hydrolase. Option B, tyrosine aminotransferase. Option C, phenylalanine hydroxylase. Option D, homogenosate oxidase. The correct answer is option A, fumarate acetoacetate hydrolase deficiency. This is the final enzyme in the tyrosine catabolic pathway. When this enzyme is deficient, fumarate acetoacetate accumulates and is converted to succinylacetone, which is the pathognomonic diagnostic marker for Tyrosinemia type 1. The full pathway begins with phenylalanine being converted to tyrosine by phenylalanine hydroxylase. Tyrosine is then converted to 4-hydroxyphenylpyruvate by tyrosine aminotransferase. The pathway continues through homogenosate, malonyl acetoacetate, and fumarate acetoacetate. Nitisinone works by blocking 4-hydroxyphenylpyruvate dioxygenase upstream in the pathway, which prevents the formation of both fumarate acetoacetate and succinylacetone. Tyrosine aminotransferase deficiency causes Tyrosinemia type 2. 4-hydroxyphenylpyruvate dioxygenase deficiency causes Tyrosinemia type 3. Case challenge 5. A 4-day-old newborn is flagged by the state newborn screening program. The screening card shows an abnormal metabolite result. The infant appears well at this time with no jaundice, normal feeding, and no hepatomegaly on examination. What is the most specific and sensitive marker for Tyrosinemia type 1 on a newborn screening dried blood spot card? Option A, plasma tyrosine level. Option B, plasma phenylalanine level. Option C, succinylacetone. Option D, serum methionine level. The correct answer is option C, blood succinylacetone. Succinylacetone is the pathognomonic marker for Tyrosinemia type 1. It is undetectable in healthy newborns, so any detectable level is abnormal. Plasma tyrosine is elevated but nonspecific, as it can be seen in prematurity, liver disease, and other conditions. Newborn screening uses tandem mass spectrometry to detect succinylacetone in dried blood spots collected at 24 to 72 hours of age. Elevated succinylacetone requires immediate action, meaning referral to a metabolic specialist without delay. Urine delta-aminolevulinic acid and liver biopsy are not used as primary screening tools. Remember, succinylacetone is undetectable in healthy individuals, so any detectable level is abnormal and demands urgent evaluation. Case challenge 6. A 4-month-old infant diagnosed with Tyrosinemia type 1 undergoes routine laboratory monitoring. His alpha-fetoprotein level is 160,000 nanograms per milliliter. Normal for his age is less than 1,000 nanograms per milliliter. This markedly elevated alpha-fetoprotein level most likely indicates option A, normal finding for infancy. Option B, vitamin K deficiency. Option C, acute viral hepatitis. Option D, severe hepatocellular injury with risk of hepatocellular carcinoma. The correct answer is option D, markedly elevated alpha-fetoprotein. Alpha-fetoprotein is markedly elevated in Tyrosinemia type 1, often exceeding 100,000 nanograms per milliliter in infancy. Rising alpha-fetoprotein signals hepatocellular damage and increased risk of hepatocellular carcinoma. The monitoring schedule is monthly alpha-fetoprotein in the first year, then every 6 months lifelong. It is important to use age-appropriate reference ranges because alpha-fetoprotein is physiologically high at birth, up to 100,000 nanograms per milliliter in the first 2 weeks. By 1 to 3 months, normal is less than 1,000. By 3 to 6 months, normal is less than 200. By 6 to 12 months, normal is less than 50. After 1 year, any elevation requires urgent workup. The key principle: alpha-fetoprotein is the most sensitive early marker for hepatocellular carcinoma in Tyrosinemia type 1. Never ignore a rising trend. Case Challenge 7. A 7-year-old boy is referred for bilateral painful red eyes and difficulty tolerating light. His mother also notes thickened, rough skin on both palms and the soles of his feet since early childhood. Slit lamp examination reveals corneal crystal deposits. Skin biopsy shows hyperkeratosis. Plasma tyrosine level is markedly elevated at 1,200 micromoles per liter. There is no liver enlargement, normal coagulation studies, and no succinylacetone detected in urine. What is the most likely diagnosis? Option A, Tyrosinemia type 2. Option B, Tyrosinemia type 1. Option C, vitamin A deficiency. Option D, herpes keratitis. The correct answer is option A, Tyrosinemia type 2, also known as Rickner-Hanhart syndrome. The enzyme defect is tyrosine aminotransferase deficiency. The hallmark features are corneal crystals and painful palmoplantar skin plaques. Critically, there is no liver or kidney involvement, which distinguishes it from Tyrosinemia type 1. The key distinction to remember is, Tyrosinemia type 1 affects the liver and kidney, while Tyrosinemia type 2 affects the eyes and skin only. The absence of succinylacetone in urine confirms this is not type 1. Treatment for type 2 is dietary restriction of tyrosine and phenylalanine, which resolves the corneal and skin manifestations. Case Challenge 8. A 2-month-old infant is newly diagnosed with Tyrosinemia type 1 following a positive newborn screen. Succinylacetone is markedly elevated. The Metabolic team is ready to initiate pharmacological therapy. What is the primary mechanism of action of Nitisinone? Option A, enzyme replacement therapy for fumarate acetoacetate hydrolase deficiency. Option B, inhibition of 4-hydroxyphenylpyruvate dioxygenase. Option C, substrate reduction of phenylalanine via phenylalanine hydroxylase inhibition. Option D, chelation of toxic copper accumulation in hepatocytes. The correct answer is option B. Nitisinone works by inhibiting 4-hydroxyphenylpyruvate dioxygenase, which is an enzyme upstream in the tyrosine pathway. By blocking this enzyme, nitisinone prevents the formation of the toxic downstream metabolites, fumarate acetoacetate and succinylacetone, which are responsible for liver damage and kidney injury. The standard dose is 1 mg per kilogram per day, divided into 2 doses, especially in infancy. The target plasma nitisinone level is 40 to 60 micromoles per liter. Nitisinone is given orally, once or twice daily. It is important to note that nitisinone is not enzyme replacement therapy. The fumarate acetoacetate hydrolase enzyme remains deficient. Instead, nitisinone blocks the pathway above the deficient step, preventing toxic metabolite production but causing tyrosine to accumulate in the blood, which is why dietary restriction is also essential. Case Challenge 9. A 7-month-old infant with confirmed Tyrosinemia type 1 has been started on nitisinone therapy. The metabolic dietitian advises the parents that in addition to medication, strict lifelong dietary management is essential. The parents ask, what exactly does our baby need to avoid in the diet? Management of Tyrosinemia type 1 requires a diet restricted in Option A, fat and glucose. Option B, galactose and lactose. Option C, leucine and valine. Option D, phenylalanine and tyrosine. The correct answer is option D, strict restriction of phenylalanine and tyrosine. This is essential because nitisinone blocks 4-hydroxyphenylpyruvate dioxygenase, which means tyrosine cannot be broken down and accumulates in the blood. Without dietary control, elevated tyrosine causes corneal crystal deposits and carries neurocognitive risk even while the patient is on nitisinone. The target plasma tyrosine level is 300 to 600 micromoles per liter. The target plasma phenylalanine level is 20 to 80 micromoles per liter. Dietary management includes phenylalanine and tyrosine-free amino acid formula, low-protein staples such as special breads, pasta, and crackers, and fruits and vegetables which are naturally low in phenylalanine and are encouraged freely. Regular plasma amino acid monitoring is performed every 1 to 3 months. Case Challenge 10. A 7-year-old boy with known Tyrosinemia type 1 has been on Nitisinone since age 3 months. He is clinically well with no active complaints. His last alpha-fetoprotein was 42 nanograms per milliliter, a rise from 18 nanograms per milliliter 6 months ago. His parents ask about the appropriate surveillance plan going forward. What is the recommended surveillance strategy for hepatocellular carcinoma in a child with Tyrosinemia type 1? Option A. Annual computed tomography scan only. Option B. Monthly liver biopsy. Option C. Regular alpha-fetoprotein monitoring plus liver ultrasound or magnetic resonance imaging. Option D. No screening needed once nitisinone is started. The correct answer is option C. Lifelong alpha-fetoprotein plus liver imaging surveillance. Alpha-fetoprotein should be monitored monthly in the first year, then every 6 months lifelong. Annual liver ultrasound or magnetic resonance imaging should begin starting at age 1 year. If alpha-fetoprotein is rising, imaging should be upgraded to every 6 months immediately. Early nitisinone initiation before age 1 year reduces hepatocellular carcinoma risk to less than 1%. Starting between ages 1 and 2 years carries approximately 7% risk, and starting between ages 2 and 7 years carries approximately 21% risk. If alpha-fetoprotein is rising or a new liver nodule appears on imaging, escalate immediately with imaging every 6 months and referral to a hepatology and transplant team. Case Challenge 11. An 8-year-old boy with Tyrosinemia type 1, well controlled on nitisinone for 6 years, presents with progressive photophobia, eye pain, and tearing over the past 3 weeks. His plasma tyrosine level is 720 micromoles per liter. Slit lamp examination is pending. What is the most likely cause of his ocular symptoms? Option A. Tyrosine crystals in the cornea. Option B. Nitisinone direct ocular toxicity. Option C. Drug-induced cataracts. Option D. Optic neuritis from metabolic crisis. The correct answer is option A. Corneal tyrosine crystal deposition. When plasma tyrosine exceeds 600 micromoles per liter, tyrosine crystals deposit in the corneal epithelium. Symptoms include photophobia, eye pain, tearing, and corneal opacities visible on slit lamp examination. The mechanism is that nitisinone blocks tyrosine catabolism, causing tyrosine to accumulate in the blood, and when levels get too high, crystals form in the cornea. The treatment is stricter dietary tyrosine and phenylalanine restriction, and the crystals typically resolve with improved dietary control. The target plasma tyrosine should be maintained between 300 and 600 micromoles per liter using a low phenylalanine, low tyrosine medical formula diet. This complication is more commonly seen in Tyrosinemia type 2, but can occur in type 1 patients on nitisinone with poor dietary adherence. Case Challenge 12. A 7-month-old with known Tyrosinemia type 1 on nitisinone has routine labs showing glucose in the urine, but blood glucose is completely normal. Urine amino acids are also markedly elevated. What does this urine finding pattern most likely indicate? Option A. Diabetes mellitus. Option B. Cystitis or urinary tract infection. Option C. Nephrotic syndrome. Option D. Renal Fanconi syndrome. The correct answer is option D. Renal Fanconi syndrome. This is caused by toxic accumulation of fumarate acetoacetate and succinylacetone damaging the proximal convoluted tubule cells. The proximal tubule is the primary site of damage in Tyrosinemia type 1 kidney injury. Proximal tubule dysfunction leads to generalized wasting of solutes. The classic Fanconi syndrome lab findings include elevated urine glucose, which is glucosuria with normal blood glucose, elevated urine amino acids, known as aminoaciduria, elevated urine phosphate, known as phosphaturia, elevated urine uric acid, known as uricosuria, low serum phosphate, low serum uric acid, low serum bicarbonate consistent with renal tubular acidosis type 2, and inappropriately alkaline urine. The phosphate wasting is what leads to the hypophosphatemic rickets we discussed in an earlier case. Case Challenge 13. A 9-month-old boy with confirmed Tyrosinemia type 1 has been on nitisinone therapy for 6 months. His metabolic team is reviewing his latest results to decide whether to adjust his nitisinone dose. Nitisinone dosing is primarily adjusted based on Option A, weight only. Option B, succinylacetone and nitisinone plasma levels. Option C, liver size on ultrasound. Option D, bone density measurements. The correct answer is Option B, succinylacetone and nitisinone plasma levels. The standard starting dose of nitisinone is 1 mg per kilogram per day, divided into 2 doses in the first year of life. The target plasma nitisinone level is 40 to 60 micromoles per liter to ensure therapeutic efficacy. The goal for succinylacetone is undetectable in blood and urine, which confirms the pathway is adequately blocked. Plasma tyrosine should be maintained at 300 to 600 micromoles per liter to prevent corneal crystal formation. Plasma phenylalanine target is 20 to 80 micromoles per liter to avoid deficiency. Alpha-fetoprotein should show a declining trend, which monitors liver injury and hepatocellular carcinoma risk. Once daily dosing may be considered in older children due to the long half-life of nitisinone, which is 50 to 60 hours. Case Challenge 14. A 6-week-old infant is brought to the clinic for a routine visit. The mother reports that the baby has an unusual body odor she describes as boiled cabbage. The infant is feeding adequately and has no jaundice. Newborn screening results are pending. This distinctive odor pattern is most characteristic of which metabolic disorder? Option A, phenylketonuria. Option B, maple syrup urine disease. Option C, Tyrosinemia Type 1. Option D, isovaleric acidemia. The correct answer is Option C, Tyrosinemia Type 1. The cabbage-like or boiled cabbage odor is characteristic of Tyrosinemia Type 1. Succinylacetone accumulates in the body and contributes to this odor. Methionine metabolite buildup, especially in untreated cases, adds a cabbage-like or boiled vegetable scent. The odor may be noticed on the urine, breath, or skin. It is clinically subtle but a useful red flag in undiagnosed neonates. Other classic metabolic odors to remember include phenylketonuria, which has a musty or mousy odor from phenylacetic acid, maple syrup urine disease, which has a maple syrup or burnt sugar odor from branched-chain keto acids, isovaleric acidemia, which has a sweaty feet or cheesy odor from isovaleric acid, trimethylaminoria, which has a rotting fish odor, and glutaric aciduria type 2, which has a sweaty feet or fishy odor. The clinical pearl, odor alone is not diagnostic. Always confirm with succinylacetone measurement. Before we conclude, I want to share an exciting resource with you. Join the Pediatric Case review community on Patreon. In this community, all lectures are organized by body system, including cardiology, metabolism, neurology, and more, so you can find what you need instantly. Every lecture is available as downloadable slide images for offline review and practice anytime and anywhere. To subscribe, simply comment below on this video and we will message you directly. No subscription links needed. Just leave a comment and we will get back to you. Let us review the 5 essential clinical principles from today's lecture on tyrosinemia. First, early screening. Screen all newborns for succinylacetone, which is the most sensitive and specific marker for tyrosinemia type 1. Second, start nitisinone early. Begin at 1 mg per kilogram per day immediately upon diagnosis to prevent toxic metabolite accumulation. Third, dietary control. Maintain plasma tyrosine between 300 and 600 micromoles per liter with a low phenylalanine, low tyrosine diet plus amino acid formula. Fourth, hepatocellular carcinoma surveillance. Monitor alpha-fetoprotein monthly in the first year, then every 6 months, plus annual liver ultrasound or magnetic resonance imaging from age 1. Fifth, multidisciplinary care. Involve metabolic specialists, dietitians, hepatologists, and ophthalmologists for lifelong management. Follow Pediatric Case review for more case-based clinical lectures. Questions or comments? Drop them below. We read every one. Thank you for joining Pediatric Case review. We hope this comprehensive review of tyrosinemia enhances your clinical practice and helps you recognize and manage this important metabolic condition. Please remember that these lectures are for educational purposes only and do not constitute medical advice. Always consult current guidelines and specialists for clinical decisions. If you found this lecture helpful, please follow our channel for more case-based clinical education. If you have any questions or insights, please share them in the comments below. We read every single comment. Thank you, and see you in the next lecture.